Good evening, everyone, and on behalf of the Friends of the Village Library of Cooperstown, welcome to the fourth in a series of panel discussions, Looking in the Mirror, Cooperstown Reflects on Racism, with today's focus on healthcare. My name is Leanne Hirabayashi, and I have the honor and privilege of co-moderating these sessions, and thank you all for joining us. This panel discussion is a response to the murder of George Floyd and the nationwide protests that erupted in support of the Black Lives Matter movement. The goals of this series are examine how racism affects our community and institutions, learn how we can confront bias and inequities at a local level, and identify actions that we can take as individuals, groups, and a community to address racism and create a more equitable Cooperstown. As I said earlier, this is the fourth, and it's also the last of the panel discussions being held this fall. We plan to start up the series again in January and February with three to four more sessions. Let me go over just a few items related to the logistics and format of this panel discussion. There will be a couple brief messages from the host and sponsor of this session. Then I'll introduce my co-moderator and our distinguished panelists. After the introductions, each panelist will make a brief 5-minute presentation. If there are presentation-specific questions from the audience or other panelists, we'll address them right after the presentation. Then we'll have a question and answer session, which will be handled by my co-moderator, Carrie Fuertes, for attendees, and it looks like we're up to almost 50 people right now. At the bottom of your Zoom window, you'll see several icons in a bar similar to what I'm showing here. Please note that chat is disabled and we are not going to be using the raise hand feature, just that Q&A tool. If you have a question, please click on that Q&A icon and send it in, and you can do it at any time. If your question is specific to one of the panelists, please indicate that. Otherwise, we'll assume the question is for all the panelists. Carrie will be monitoring the Q&A tool and asking questions on your behalf. Please note that we may not be able to get to everyone's questions, and I appreciate your understanding on that. These panel discussions are being recorded, and a link to each recording will be made available on the Friends of the Village Library webpage. And now a brief message from the organizer of the panel discussion, the Friends of the Village Library of Cooperstown. The Friends of the Village Library works closely with the library to sponsor educational and entertaining programs for the Cooperstown community. This series, Looking in the Mirror, Cooperstown Reflects on Racism, is an expansion of the annual Sunday Speaker Series scheduled from October through May. That is the monthly Sunday Speaker Series. On the Friends of the Village Library's website, you will find a list of resources on racism that will be updated regularly to include recommendations and information provided by the panelists. The League of Women Voters of the Cooperstown area is grateful for this opportunity to join the Friends of the Village Library in this panel discussion. The League believes that diversity, equity, and inclusion are central to its current and future success in engaging all individuals, households, communities, and policymakers in creating a more perfect democracy. And we would like to take this opportunity to remind the audience of important dates related to the election. If you haven't voted already, we encourage you to take advantage of early voting, which started last Saturday, October 24, and continues through Sunday, November 1 at the Otsego County Meadows Complex. Times do vary, so please check Otsego County's website, that's otsegocounty.com, for details. November 2 is the last day to apply in person for an absentee ballot. November 3 is Election Day, with polls open from 6 a.m. to 9 p.m. It's also the last day to postmark your absentee ballot or deliver it to your polling place. You can find all of this information by going to the Cooperstown League of Women Voters website. That's lwvcooperstownarea.org. Finally, another great resource is vote411.org, where you can get a voter guide for this election with issue-related questions too and answers from candidates. Now let's move on to the introductions. And my co-moderator, Carrie Fuertes, who is having some technical difficulties getting on right now. So I'm hoping she'll join us. She is the section chief of breast imaging at the Bassett Medical Center. She's originally from New York City of Cuban heritage. Carrie did her undergraduate studies at Colgate University and medical school at Boston University. She initially did an internal medicine residency at St. Luke's Roosevelt in New York City and a second residency in radiology at Albert Einstein Montefiore Medical Center. She did a fellowship in breast imaging at Yale University. Carrie came to Bassett in 2006 as a general radiologist, becoming section chief in 2013. She lives in the village of Cooperstown, where she and her husband have raised 2 daughters. And now here's a brief intro to each of our panelists in alphabetical order. James Dalton has been a physician at Bassett Medical Center since 1988. He earned his undergraduate degree from Princeton University and completed medical school at the University of Washington School of Medicine and his residency at Bassett here in Cooperstown. Jim is currently the Director of Medical Education and the Program Director for the Internal Medicine Residency Program. He has also volunteered at the Oneonta Free Clinic for more than 10 years. Jim lives with his wife, Deb, outside of Cooperstown. Both are actively involved in community activities and look forward to those being more in person. Let me preface this next introduction by saying that Subhashini Daniel may not be able to join us as she was called in to do emergency surgery. If she can, she will join us partway through the session. Subhashini Daniel is a cardiac surgeon and director of the Heart Failure Program for the Bassett Healthcare Network. She is a native of the Pacific Northwest, born and raised in a suburb of Seattle. She completed both her undergraduate work and, like Jim Dalton, her medical degree at the University of Washington. She went on to complete a residency in general surgery at the University of Vermont, followed by fellowships in minimally invasive thoracic surgery at the Swedish Cancer Institute in Seattle, and cardiac surgery at the University of California, San Francisco. She joined Bassett in 2014 to further pursue her interest in practicing in an underserved region, as well as working to develop innovative healthcare delivery systems. She made the move with her daughter, and both have been excited to make Cooperstown their home. Reginald Knight is the Vice President of Medical Affairs for the Bassett Healthcare Network, A.O. Fox Memorial Hospital, and Director of the Bassett Spine Care Institute. Reggie was born in the Bronx and raised on Long Island, with a majority of his education in Central New York, at SUNY Oneonta for undergrad, Upstate Medical Center for med school, New York Medical College for his orthopedic residency, and University of Rochester for a fellowship and faculty member. Reggie enjoys hiking, gardening, golf, tending to his property, and as a younger man, studying the martial arts. He is the proud dad of 2 daughters, 2 grandchildren, and happily married to the same woman over 4 decades. Candace Shannon is a research scientist in the field of medical sociology. Her training and work experience in entrepreneurship have centered on race, ethnic and socioeconomic differences in health. Candace graduated from Tufts University with a BA in psychology and from the University of Maryland, College Park with a master's in sociology. Before moving to Cooperstown, she worked in the Department of Psychiatry, College of Medicine at the University of Illinois at Chicago as a senior research specialist for 3 large federally funded longitudinal studies. Candace is also an author in peer-reviewed academic publications on topics related to the effects of different forms of workplace stress on health services utilization and the effects of racial discrimination on work-related illness, injury, and drinking outcomes. She has also taught Introduction to Sociology. Her interest in health services usage and the social coping resources used in dealing with stressful life events and illness segued into her starting a company to provide support to women experiencing medically related hair loss. Candace is the former president of the Brookwood School in Cooperstown and also serves as a member of the Friends of the Village Library and the Community Foundation of Otsego County. Finally, Vince Solomon completed his undergraduate degree at Howard University in Washington, D.C. He holds a dual master's in social work and public health from the University of Pennsylvania and an additional master's in special education and applied behavior analysis from Arizona State University. Vince has provided clinical service across various healthcare settings, including palliative care, emergency medicine, and psychiatry, and has also worked with individuals with developmental disabilities, focusing on autism spectrum disorder. Vince has served in different healthcare systems with locations including Washington, D.C., Pennsylvania, and Florida. He's currently serving as a psychiatric social worker at Bassett Medical Center's Department of Inpatient Psychiatry, an instructor at Mohawk Valley Community College, and holds an administrative position at Family Enrichment Behavioral Health Services Incorporated. Vince has had a keen interest in the intersectionality of racial disparities in healthcare among minority groups in the United States since 2005. So I'm going to go ahead and stop sharing my screen. And we'll begin with our first panelist, Candace Shannon, to talk about, for her brief presentation. Candace, go ahead and take it away, please.
Sure, thanks. Thank you, Leanne. I thought I would start by identifying what we're really talking about when we're discussing racism in healthcare. Racism can be institutionalized, it works between individuals, and it's also internalized by individuals. We're not talking about racism just as individual acts or an offensive term. As researchers, we look at patterns, and there are experiences that are happening to the same groups of people, and these patterns either change or persist over time. When we discuss racism in the American context, we're looking at systems of inequality and how these systems create and perpetuate disparities in health conditions, mental health, and mortality. Also, when I speak about race, some of what I will touch on is from some personal context as a Black immigrant woman. But remember, race in itself is a complex topic. We know about racial disparities. What we know about racial disparities is gleaned from research on different racial groups. Much of what you would see like on a census checkbox, white American, Black American, Pacific Islander, check. However, a lot of research on the effects of race and racial discrimination has focused a lot on the experiences of Black Americans. It's also important to know that race is only one factor in the social determinants of health. Socioeconomic differences, this would be education, occupation, income, age, gender, ethnicity, and social class. They all work together and independently to influence health. So the intersection of different socioeconomic factors will have more powerful effects on health. For instance, a woman of color, a non-native English speaker, will likely experience more negative outcomes. Likewise, a provider who is a woman of color, a non-native English speaker, will likely experience greater adversity and obstacles in the course of their career. Time is also a social factor as people are living longer with chronic illnesses due to technology and medicine that was not formerly available. You can see that these are often very complex relationships because many socioeconomic statuses are related to each other. If you've ever heard the phrase, your zip code can be more important than your genetic code, people with higher incomes, education, and occupation have better health outcomes and a greater life expectancy, which might be expected. Your genetic predisposition can have less of an effect. Well, where you live is influenced by a range of social factors, and all these are influenced by different opportunities you had based on racism. I can't possibly go into all the markers of the relationship between race and health, but there are some very depressing statistics. Black women, for example, are 3 to 4 times more likely to die while giving birth than white women in the United States. This is shocking, even more so because over half of the maternal deaths occur in the postpartum period, and 1/3 occurring only a week after delivery. Black Americans have the highest mortality rate for all cancers combined compared with any other racial and ethnic group. Black, Indigenous, and people of color in the US experience more illness, worse outcomes, and premature death compared to whites. People usually see health only as a personal responsibility, but don't realize that there are larger macro level and structural forces that shape health. When we talk about racism in healthcare as a system, specifically, we're looking at the policies, the insurance systems, the social factors that contribute to disparate health outcomes. And there are different barriers to quality healthcare. So the social determinants, where you live, where you work, your levels of stress at work, where you pray, your access to food, affordable housing, your likelihood of entering the criminal justice system, your general safety, all of these things are consequences of racism. So systemic racism is not practiced by one race or one individual, and it certainly doesn't only apply to the healthcare system. However, systemic racism and racial discrimination on its own and independent of other social determinants is a strong predictor of chronic stressful life events, environmental stressors, and trauma that can result in physiological changes in your body that influence your mental and physical health. Racism is linked to depression, anxiety, poor sleep, negative affect, substance abuse and use, and post traumatic stress. Because I already know all of this research, to this day, I have not watched the video of George Floyd's murder and many of the other acts of violence towards Black bodies. As a Black mother, these are way too traumatizing for me. What we know is that certain groups of patients are getting different care, and the quality of care varies significantly by race and ethnicity. Racism in healthcare applies both to the effects on patients and the effects on providers. Race and ethnic minority patients have differential access to health insurance, health services, and quality providers. These differences are all influenced by the social determinants I mentioned before. The resources that hospitals have differ greatly by neighborhood and economic and public policies. Healthcare studies also do not include enough minorities in clinical trials to know how certain treatments will affect different groups. Racial and ethnic minority providers have differential access to healthcare systems, starting with differential access to quality elementary education, all the way to medical training and education. Healthcare policymakers and healthcare leadership and governance continue to be predominantly white. Leaders need to talk honestly and openly about race and racism among staff and patients, implement medical educational training and institutional policy that address these issues of bias, workplace stress related to discrimination and racism, including increasing diversity in medical schools and medical staff. Another factor that greatly influences one's experience of racism in healthcare is discrimination at the patient provider level. So quality of care is also influenced by the implicit biases of providers. There are different assumptions made about different patient populations, along with their intersecting factors, and this has been shown to affect whether appropriate options for care are communicated to patients and how clinical decisions are made. I myself have certainly been in that position where providers dismiss my concerns. And of course, I tell them at some point that my husband is a physician, and things turn around really quickly after that. It's really quite remarkable. On the provider level, there are also issues with bias. Providers have to care for racist patients. Yes, patients can and do refuse care from minority providers due to bigotry. Black and Asian providers report this more than their counterparts. Minority providers also face greater workplace discrimination, not only from patients, but also from their colleagues. They are faced with racial bias in their clinical education and in the ways their performance is evaluated, including bias in how disciplinary actions are administered. I cannot emphasize enough that these are all notable chronic workplace stressors. We have to continually train a new generation of providers and examine the institutional and governing policies that will protect patients and providers of color from unequal outcomes.
Thank you very much, Candace. There are no specific questions regarding your presentation. Do any of the panelists have any questions at this point for Candace, or any comments? All right. Reggie, you want to take it away now?
Oh, certainly. I'm just going to share my screen here. I put together a little PowerPoint presentation. From what Candace just gave us, this is going to be somewhat repetitious, but I think for tonight's discussion, it doesn't hurt to have a little bit of reminder of what's going on from one panelist to the next. So this will just take a short period of time to get through this. The whole question is why we're here is why should we be concerned about the impact of racism on the health of our communities? A major question for everyone who's in healthcare and everyone who lives in a specific community in the United States. In 2020, excuse me, Professor G stated that racism is a social toxin, is not only morally unacceptable, but potentially lethal. He follows that statement up with the fact that racism is a system of beliefs and practices that serve to reinforce the power and well-being of whites at the expense of people of color. Very broad and powerful statements that he came out with in 2007 and is in Healthy People in 2020. So we know that racism, as Candace said, is one of many social determinants of health, but it is a major social determinant that is impacted by multiple others. The World Health Organization has actually commissioned the Commission on Social Determinants of Health, but this is not something that is not only worldwide, but the United States is also looking at this very, very intensely with the National Partnership for Actions to End Disparities and other groups. We wonder why we would be so concerned, and we have to realize that 80% of a person's health is determined by the social and economic factors within which they live. And so only 20% of the things that we as physicians do truly impact our patients' health. It's really their zip code, as Candace mentioned before, and all of the other socioeconomic factors that they are faced with. So, as noted, the impact of racism is associated with multiple health conditions: heart disease, low birth weight, clinical depression, sleep deprivation, obesity, but ultimately it increases the overall mortality of our people of color. It's important to realize that it is illustrated, as Candace said, by multiple things: the segregationist policies for housing, schooling, and workplace, bank practices. We all have heard so much about the redlining that's begun well back in the last century, food and environmental insecurities. Neighborhoods of color have some of the highest crime rates in the nation. And overall, the negative portrayal of people of color in the media. The mass incarceration. We just think about how we dealt with the 1990s and the drug explosion and how powdered cocaine was looked upon by law enforcement versus crack cocaine, where crack cocaine was primarily in the African-American communities and powdered cocaine was in the suburbs and thought to be a much different process. Voting restrictions and immigration policies are also very important ways that systemic racism impacts people of color throughout the world. If we think about it, the impact of racism is what we call intersectional, in that, as Candace mentioned earlier, depending upon your gender, your race, racism has affected individuals by individual factors. Social class, sexual orientation, and again, immigration policies all impact how the systemic racism will affect your overall life. Also, it's cumulative. It's death by 1,000 cuts. Not one thing necessarily is going to be the factor that affects your healthcare. It's more a buildup of things that happen over time. And if we think about it, there are individual expressions of racism which are very, very personal. And if you hear them, you see them, you recognize them right away. They're easily recognized, but they're just the tip of the iceberg. And we'll have a conversation about that in a minute. More importantly, systemic racism forms a foundation upon which cultures devastate minority ethnic groups worldwide. It's not just the African American community, it's the Asian American community, the Arab American community, Latinos, and Native Americans. This ethnic or systemic racism doesn't only affect the United States. There are other major countries that have effect: Australia, Brazil, China, Japan, South Africa, to name a few. So the underlying message there is that healthcare of marginalized groups is adversely affected by systemic racism. This is a little pyramid I like to show you. It's an adaptation from Professor G from 2007. And what it's showing us is that society has a waterline. And there's individual acts of racism above the waterline. Those things are the hate crimes and the slurs, and they're easily detected. They're personal affronts, and they are just the tip of the iceberg. Below that the waterline, we have the systemic acts of racism, the policies and redlining, the procedures for mass incarceration, and the cultural norms that we see here. Those things are more difficult to detect. They are often delivered by subliminal messaging, and they're more difficult to address. That's the foundation that we see. And so the bottom line is that systemic racism results in healthcare disparities, which affects all members of our society, and the minorities and peoples of color are more affected than any. And so in closing, I want to thank you very much for your attention. Bassett Healthcare is trying its best to put forth a good impression and good policies and procedures for systemic racism. We hope to improve our community and ultimately improve our nation. Thank you very much.
Thank you very much, Reggie. And now, Jim, would you like to say a few words as well, please?
Sure. Thank you, Reggie and Candace. The people who are listening may, well, as you're looking at this group of lovely people in front of you, you may wonder what somebody who looks like me is doing on this panel. And I think there are probably a couple of good reasons. The biggest one, I think, is that when we talk about systemic racism and about how our society and our healthcare system and every piece of our society has contributed to this, has created this, not just contributed, but created it. It has a lot to do with people like me, people who are in positions of significant influence in healthcare. And you know, but the process of me getting to this position probably has something to do with some of my intrinsic capabilities, but it has absolutely nothing to do with any more intrinsic capabilities than anybody else who may have been looking at the same opportunity, who had a different color skin. And he or she didn't get the same opportunities. So we need to understand that there is such a thing as white privilege, and those in our society and in my age group certainly, but even still now, we live in a system that allows us allows us with lighter skin to have an easier path forward. I got stopped coming back from a Fly Creek Philharmonic rehearsal a couple of years ago on Cemetery Road in Fly Creek. And man, was I pissed off, because it was a late night. I'd been doing something that I thought was for the community, and I guess I'd been speeding. And I was mad, but I wasn't worried that I was going to be dead. I've never worried that I was going to be dead. And I never had to have the talk with my son about how to behave when a police officer stopped him. And that is a privilege that, you know, I'm not sure that I've thought about it. I'm 67 years old. I'm not sure that I've thought about that enough over the course of my life, how many parts of my life have been easier. And so George Floyd did, in many ways, for a lot of people, bring that into focus. So those of us who are white and who are in the majority, and I'm delighted that I'm not in the majority on this panel, need to start thinking about that and be sensitive to that. And so we very much have to be on these panels and in these discussions, because this is a society where we all live and where we all are a part, and we have to live in community and figure out how to do that the right way. There's another reason, since this is about healthcare. I am the director of the graduate medical education programs, the residency programs at Bassett. And I've been doing that for almost 20 years. Most of our internal medicine residents are international, and most of them, many of them, are of color. In 2016, in December of 2016, I got a Facebook notification. After I figured out how to use Facebook, I looked at the message from one of our residents who had just graduated, and she was with her son, her husband, and her son on a beach in Thailand. And it was just this gorgeous picture. A beautiful young woman, beautiful husband, son. And I looked at that and enjoyed it for a minute. And then for some reason, I decided to scroll down. And the next message on the Facebook page was from a friend of hers in Minneapolis. And the friend said, I don't know whether I can stay here anymore. Last night, I was walking back from work. She was another doctor. I was walking back from work, and I was assaulted by this man who was probably 20 years older than I was, who shoved me, called me a name, and told me to go back home. Now, this particular woman was a citizen of the United States, and but she had a different color skin than he did. And for some reason, I mean, that has been just an enormous, that made an enormous impression on me. And it made me send a message out to all of our residents saying, please, let's talk about this. And we have had, I think, more conversation and better conversation about those issues since that has happened. We at Bassett, I think, probably represent the most diverse racial and ethnic population in this county. I think even if we include Oneonta, we probably do. And that is not what I just described having happening in Minneapolis. It's happened here. And we have nurses and doctors and other healthcare workers who have experienced that. It's not right. And it's something that we have to address and we have to keep talking about. So I appreciate the opportunity to be part of this group and to be able to participate in conversation. And it's a conversation that has to be ongoing, not just here. I suspect the 50 people who are listening I suspect we're preaching to the choir, but maybe not. I hope not. I hope there are more people who are tuning in and thinking about this differently than they ever have before. So thank you for the opportunity.
Thank you very much, Jim. There is one question specific perhaps to you from, and I see, Carrie, that you have joined us, so I'll be handing off the question moderation to you whenever you're ready. But there is a question about, do we have the numbers on the diversity of the Bassett Medical School?
The Bassett Medical School, you do.
I think. Can you hear me?
Question.
Yes,
I
think what the question refers to is the Columbia medical students at the Bassett campus. What is the diversity of the class?
That particular part of medical education is not under my purview, so I would be guessing. the vast majority of the Columbia Bassett medical students are American citizens. They're not international.
Okay.
And as far as racial diversity, I can't tell you what it is. And that's,
We'll find out. We'll see if we can find out about that.
yeah.
Okay. Thank you. Sorry, Jim, to ask you a question that wasn't part of your purview. Okay. Are there any questions from the panelists or comments from the panelists, either to Reggie or Jim at all? Okay. All right. So we'll end with the presentations with Vince Solomon. Vince, go ahead.
Good evening, everyone. It's just refreshing to sound like that broken record that everybody needs right now. It is a good thing to know that the message has been consistent, not only across the members of this panel, but in the other discussions that have preceded this one. My message is not going to be any different. The fact of the matter is, racism is something that is so institutionalized that it has become unnoticeable. It is ubiquitous and it exists in every section of society. As it applies to healthcare, we understand that there has been a systematic and historical lack of trust when it comes to minority populations seeking help from medical professionals. It is known that they receive less quality health care. And even to this day, we talk about a lack of trust from white providers to Black patients, where their level of pain is usually not perceived at appropriate levels. And when they come seeking help, a lot of the times they are treated as though they are drug seeking and other factors that play into that. There is also an overwhelming amount of evidence that shows that, especially when it comes to things like survival rates postpartum, that when you have a Black provider providing services to a Black patient, it's in excess of 5 times the survival rate of new mothers. One of the things that people tend to do is brush past our history when it comes to how things were, because it's a painful time, it's an uncomfortable time. But let us not forget that there was a push for Black representation of providers at the turn of the century, an initiative that was cut very, very short by the Flexner Report in 1910, which saw 5 out of the 7 Black medical schools closing based on criteria set by one individual. It was shown that, at least by modern standards, they would have had at least 29% more representation of Black providers had those schools not closed. We are talking about a system that is set up to facilitate microaggressions. And for a lot of individuals, especially if you are white, it is easy enough to dismiss it and turn your back. Even if you had an unpleasant interaction with a person of color, it's easy to dismiss it a lot of times. It's a system that is built for that. You have, however, the Black individuals who see this as an affront, and it is an affront because it is repeated. There are repeated assaults, repeated microaggressions that add up over time. 2 of our panelists did mention that the cumulative effect, and since my spin is mental health, we have to understand that these things tremendously affect the psyche of individuals who are made to feel as though they are second-class citizens, especially in the country of their birth, and to be treated as other than, less than, to have a qualifier when it comes to American. So you are African American, Asian American, not just American, where white is seen as the gold standard in America, and everybody else is some derivation of what is seen as the gold standard, means that as a default assumption, you are less than unless you are white. It creates a system where you have every other minority group trying to pay the wages of whiteness. And unfortunately, Black individuals tend to remain at the bottom of that rung, especially since they cannot escape the color of their skin. I am talking about systematic distrust. We know about the Tuskegee experiment. We know about the father of modern day gynecology, who did the majority of his experiments on slaves who had no choice in the matter. There was no anesthesiology. And the important fact to note about that is not that we made scientific advances through those efforts and it's something that should be forgotten. We need to focus on the fact that that kind of trauma is something that is passed on. It's passed on laterally when we start talking about these horror stories being sent out to other individuals in your community, and then vertically, because this is something that you pass on to your children. When they start talking about you cannot trust these providers, the damage has already been done. And this is something that we need to be mindful of. Another point that is important to note is that while it's a part of history, it's not distant history. We can appreciate the institutionalization of eugenics in the United States, where you have minority populations who were sterilized, and it saw a recent spike in the 1930s, so it was not that far behind. Between the 1930s and the 1960s, there were minority populations that were forcefully sterilized to, quote unquote, avoid creating more individuals who may be negative, have a negative impact on society. Now, again, people may say the era of the civil rights, you're talking 1930s to 1960s. I would like to bring to your attention that South Carolina, which was probably the last holdout with respect to state-supported eugenics, they very quietly discontinued that practice in 1985. It is not so far in the past that these ripples are not being felt in a profound way in minority populations. We are here in the afterglow of racism, and the fact that it does not hit you head on in your face does not mean that it is not alive and well. I love the imagery that Dr. Knight put up of the iceberg. Everyone tends to assume that racism must be so overt. And we have many critical moments in history that has shown that every advancement that has been made in terms of civil rights, especially for minority populations, it coincides with a lot of these racist practices being more covert, less perceptible. And these are things that we need to be mindful of. We have to appreciate that when somebody tells you that something is racist, they are not necessarily saying that you are racist. We have to appreciate that this is a system that was not built by us, but as of right now, we seem to be forced to participate in a structure that is built against minority populations. It ought to create a sense of discomfort. And this is where I'm going to close, because if the things that I'm saying makes you feel uncomfortable, good. If it makes you feel comfortable, that's good too. We need to have these conversations, and we need to know that discomfort is necessary to facilitate change. Right now, we can call things out and say it's not right, and that's perfectly fine. How long is that going to last? We do not have to be personally affected by something racist to know that it is wrong, or to feel uncomfortable about it. I encourage you to exist in this discomfort. Let that persist and work towards change so that we will improve things that we know are not right in the first place.
Thank you very much, Vince. Carrie, would you like to start the Q&A, please?
Yes. Well, we have an answer to the current class of Columbia Massive medical students. There are 9 white students and 1 Asian student. Another question came in that is the following. Bassett, as a network in the region, will have a large part to play in moving the needle forward towards equality in healthcare. What would you recommend as the next steps that it should take or must have in the actions policies? And this is a question to all panelists. And they wanted Candace, maybe she could start with the answer. They wanted to hear from the panelists.
Sure, I can start. Of course, I don't have all the answers, but there are some very clear answers in the research of where things should start, and that should be on the top level. So we're talking about healthcare boards and healthcare management and healthcare leadership. A lot of people in these positions are not even aware of this research. This research has been going on since the early 80s. The social science, where I come from, we have been talking about this forever, it seems. And a lot of medical professionals don't know a lot of this research, and it's not because they don't care and it's not their fault. It's just an academic disciplinary thing. Sometimes one discipline doesn't talk to the other. So that's why I wanted to become a social psychologist within the field of sociology. And then I started working in medical sociology because all of these things are really intertwined. I think it's not an easy thing. I think that organizations need to look within, and a lot of them have, and I know Bassett has as well, and I'm sure other panelists will talk about that. But in terms of what's the next step for the organization, the policy, a lot of organizations have policies, but there's nothing backing it up. So what if a worker has a complaint about their experiences at work, or dealing with patients that continually berate them, or say they don't want a Black doctor, or say really rude things, or things like that? What is the policy for that? There are legal policies, there are government policies on how to deal with patients, but then you have to look at what's the hospital policy for dealing with certain patients like that. And the same goes the flip way around, of course, where for providers that are not acceptable, sometimes, the only thing you think, oh, they will get fired. A lot of times they don't. Some providers are completely unacceptable and they're still there and everybody knows it. So we have to look at systemic ways to deal with some of these issues. That's all I'll say for now.
I think I'll comment on that a little bit. I think that it's a very complex situation, as noted by the other members of the panel. I would say that, as Vince said, we can't ignore our history, but we have to say that we're willing to start a new page. Bassett is under new leadership right now, and Dr. Ibrahim has made it perfectly clear that diversity and equity are important values that we need to espouse. We have recently drafted a statement which gives a very clear picture of what we believe are important. But as you said, Candace, we've had plenty of policies before, and actions speak louder than words. So moving forward, we'll have to see if we can come up with actions that represent our true beliefs as an organization. And only time will tell about that. But Vince's statement about making sure that we are in this uncomfortable zone is important, because what we've done since the spring of 2020 is to open up these conversations. And some of these conversations are uncomfortable. And we need to be able to have these uncomfortable conversations, agree to disagree to a certain extent, but recognize that we all have some quote unquote skin in this game. And it's important to recognize our own biases and intolerances, and we all have those as well.
I'll weigh in a little bit here too. I've had the privilege to be involved with a group, a work group on disparities at Bassett for the last 5 years, and we have tried to come up with a propose, I should say, a strategy for the institution to deal with disparities in healthcare. And one of the very fundamental things that you have to do if you're going to deal with disparities is know what they are. And we don't even know what they are. When we look at our different populations, let's say, for instance, we're trying to find out how does prostate cancer get treated in different populations that we serve. We don't know the answer to that. We know how prostate cancer gets treated overall, or we know how mammograms are obtained for women between the ages of 50 and 75 overall, but we have just started now to scratch the surface on looking at those dashboards in different populations within our overall population. And part of the reason for that is economic. You know, if we're going to look at how do people in lower socioeconomic groups or people who aren't insured, but they live in our population area, how do they get treated? And what if we find out that they don't get treated very well, which is what we're going to find out. What do we do about it? It puts us, once again, it goes back to Vince's point, it makes us uncomfortable. And we should probably do something about that. But if we don't even know what it is, we can't do anything about it. So I think one of the first steps that you have to do as an organization is find out, what are you doing and what aren't you doing? What are you doing well and what are you not doing well? And really apply that to our minority populations, our and race is not the only group, is not the only disparate metric, I think, that we have to look at. But it's the one we're talking about here, and it's an important one. And we don't know those answers. We don't know how do women of color get mammography services. Carrie can probably might be able to. Carrie, please correct me if I'm wrong about that, but I think we don't. And but until we can't fix the problem until we know what it is. Now that's looking at that's not looking at the root cause, certainly, but if we have enough data to look at inequities, then maybe we'll get a little more uncomfortable.
I'd like to just dovetail on what Jim just said here for a moment. It's very important to recognize that we're talking about systemic racism here today, primarily because racism is such a 900-pound gorilla in the room when it comes to the social determinants of health. But in our population here in Central New York, the disparities that Jim mentioned are very important. And it's very important to recognize that even the majority ethnic groups have marginalized segments of those groups. And their healthcare is affected in the same way. And it's still a systemic issue, which ultimately comes down to a bias or a racial platform. So yes, the color of your skin is very, very important. But as healthcare professionals, we have to recognize that it's not the only social determinant, but as noted on several times tonight so far, it is a very large determinant.
I just want to add a point to that, in back to mammography and breast imaging, that studies are now coming out specifically focusing on African American women and Latina women because of the incredible discrepancy that there has been in terms of what has been published traditionally. And I do not think that information is just in breast imaging. I think that a lot of what we follow in our training is very biased. The papers, the patient clientele, the studies the patients that they pick. I think that it's been very biased, and they lump patients together when they don't look at the differences. We're trying to improve on that right now, at least in breast imaging. There is a question that can be sort of piggyback on what we're speaking about, and it's the following. Bassett
Karen?
yes.
Just briefly, I don't know if Vince wanted to chime in as well.
Oh.
Did you have anything you wanted to say?
I would be happy
As
to
well.
wait for the additional question.
My apologies.
Okay, all right, sorry, no worries.
Vince, are you going to speak?
After you finish the question, it's fine.
Oh, the question is, it's a piggyback question, which is the following. Bassett had just hired an individual in a new position labeled People and Diversity Officer. Is this a hopeful sign? And what specific actions do you envision this individual? I'm sorry, the question moved on me. 1 second, because people are writing in a lot right now. And what specific actions do you envision this individual to engage in? Would these actions be effective in dealing with racism in our Ambassador Healthcare? And Vince, if you could start, and then we can walk
Okay.
in the other direction.
Certainly. One of the things that was very powerful that you said is that new information is coming out to more effectively represent differences in the populations that are served. We also have to recognize the machine that exists at Bassett, which is specifically designed for rural practice, which means there is an acknowledgement of a difference and a different need. It means that every department has some adjustment that may look different than other medical institutions. It means that this is one of the ways in which we have to approach it. By the time we get to the disparities for a subspecialty like imaging, by the time it gets to Dr. Fuertes, it is only a symptom of the deeper problem, of this systematic problem. And every medical professional on this panel could probably speak to that at some point when it gets to them, it's already so far down the pipeline that all they can do is engage in mitigation. One of the good things that Bassett has is an education system as well. We have the medical students and we do have residency programs. Integrating consciousness across those settings is usually something that is helpful, because now people are going to be trained to take those things into consideration. With the new position that has been instituted, my expectation is that they will be mindful of those things when they start trying to effect change, because a lot of the times people try to effect change at the end of the pipeline because that is what is most visible, but the least effective. So you have to go up the chain. And I would hope for interdepartmental collaboration, because it's not only in one specialty at Bassett or throughout the healthcare system, it is across the board. And so this individual representing this department would be mindful of those things and not only apply changes administratively to try to have a more integrative mindset, but also to be aware that there is a perspective that needs to shift when it comes to care. It also piggybacks off of what Dr. Knight said, because it's not always going to be as obvious as that's the Black person. There must be some disparity there. It is you have unique circumstances where it may not be as obvious. And so we are going back to the fact that there are a lot of covert circumstances. So addressing it on a multidisciplinary level, I think would be absolutely necessary in terms of effecting change.
Also, just to dovetail on that again, thanks, Vince. I know that we have, the network has elevated the importance of diversity to the senior vice president level for people and diversity. And I believe that there will be further importance shown to the fact that a specific Office of Diversity, I believe, is planned. But as you say, things have to come both from the bottom up and from the top down. And the fact that the network has elevated someone of that title to that level, I think speaks to the importance that the network leadership has placed on diversity.
Thank you. There is a question for Jim Dalton, and it's a two-part question. The question is the following. Does the educational experience for the Bassett residents include any training on the effects of racial and cultural diversity on patient interaction and healthcare outcomes? That's the first part. And the second part is, do you think the Cooperstown community does enough to welcome international residents here? If not, what else can be done?
So the answer to the first question is yes, we do have a curriculum on diversity and the effects of social determinants of health on health outcomes for our residents. Happily, they engage enthusiastically in those discussions because our medical residents primarily come from other countries. They have seen racism and poverty and discrimination and social determinants of health to an extent that we may never see it here in many cases. And they turns out they're going into medicine for the same reason that most of us do, to help and to understand the human condition a little better. So yes, we do. It's probably not enough. It should be more. Actually, we're in the process of trying to ramp that up significantly. And tune in next year, and we'll see. I think it's going to be even more pronounced. And I'm looking at least 5 people here who I'm going to ask to help with that. The second question about what was the second question? Oh, are we welcoming enough? That's an interesting question, Carrie, and whoever asked it. I'm reminded of the comment that Ta-Nehisi Coates made at the Opera House last year when he was asked what can white bread Cooperstown do to help this problem with that we have such a small number of people of color who live here. And he said, I don't know, maybe you should have a conversation about that or something like that, because he looked around and he said, I'm Black. I think it's pretty nice here. Why wouldn't I want to live here? And I think there is probably some of that. And it's so, and I don't mean that towards myself or anybody else who's listening to this in any kind of insulting way, but we probably are pretty happy with ourselves the way we are. It takes energy and effort to invite somebody into a community. Having said that, I will say that when I overtly ask the residents that question, they feel welcome. They say they feel welcome. Now, I don't know whether I believe them or not, but they do. And many of them stay. We have now some fairly significant diversity in our senior staff because they were residents here and they stayed. And I think, and you see them at the unfortunately we didn't have the Harvest Festival this year on Main Street. You see our residents coming down to that. Not all of them, but not all of us go there either. And you see them contributing to the community in other ways. So the answer to that is I hope so. But if whoever asked the question has any other ideas, I would love to hear them. One of our senior staff, who was a resident here, organizes a Diwali party every October to celebrate the Festival of Lights in South Asia and in the Hindu culture. And there are a lot of people from the community who come to that. It is actually mostly for the Basset community, but there are infiltrators who come in there. And this is Anush Patel. I'll offer him to try to expand it out to the rest of the community.
Thank you. There's another question here for the panelists. In the panelists' opinion, about how or whether Basset should seek guidance from the community members who represent populations with significant social determinants of health. For this discussion tonight, people of color who experience racism. So I guess the question is whether Basset should seek guidance from the community members who represent populations with significant social determinants of health.
Yes.
Most certainly so.
I mean, it's one of the things that has been effective in many healthcare systems. It's usually designated as community outreach, but the idea is to figure out ways to tailor your services to the community within which you reside. And so it would absolutely be useful. It would help the hospital system as a whole get a more effective pulse on the community. And it's not to say that they're not doing a great job or that they're not putting in effort. It's just a matter of fine-tuning the information we already have and probably availing ourselves of resources that may not have been too obvious to us as a healthcare system within this community. So it would be useful.
I'll just piggyback on what Vince is saying, that yes, I agree, yes, that there should be community outreach. I think the average Cooperstonian or people from around here, because there are other communities around here, would say, oh, there's no diversity here, or there aren't, I've seen it on Celebrate Cooperstown, there aren't any Black people here. I mean, on some level, that's just kind of, discounting my existence, right? Basset brings a lot of people of color to this community. Just because you don't know who they are doesn't mean they don't exist. So I think that is an important part of the step, is to learn about who's here, and how we can meet their needs to welcome them to the community. There are lots of different people in this community already working on that and recognize that issue, that there are, it's a very isolating community just from the fact that it's rural, but it's even more isolating. And this is, we're talking about compounding variables here, intersecting variables. If it's even more isolating if you're a person of color. And some of them don't stay, of course. So that is something that should be looked into and addressed. Not necessarily, it doesn't necessarily only have to be Basset. I should state that. There are lots of different organizations that I know are already thinking about this and working on it. It's not just the hospital's responsibility, but of course the hospital has a big role in this community.
Thank you. There is something that just came in about the Basset, Columbia Basset class. It's what I said before, what I was told is not quite correct, since there is one person of color from Ghana. So it sounds like there might be 8 whites, one person from Ghana and one person from somewhere in Asia. There is a two-part question as well. And first is for Vince. And the question is, as a provider, can you describe your general experience with patients relative to race issues? And then the reason I think the person is asking is, they state, for reference, a number of concerned people are hoping to set up a welcome digital hub to better assist new arrivals and address their feelings of isolation. This is a new effort since the murder of George Floyd, which has opened up many eyes to the need to accelerate actions. So, Vince, as a provider, can you describe your general experience with patients relative to race issues?
Okay.
And everyone else, please.
So again, I mean, it may fall into the description of a certain amount of discomfort, not necessarily for myself as an individual, but there are things that are brought to your attention. A lot of the times you would approach patients who are scared. The typical demographic is usually an older white woman. As bad as that sounds, I very often find myself putting in a lot of extra effort and energy, working towards making individuals such as that feel comfortable, which is, of course, part of the job. So we can expect that, especially if they're in the hospital, especially in my department, they are part of a vulnerable population. What I have found is that you do have many individuals who are not afraid to express themselves. You see people who are putting in the effort. When it comes off in the form of, I have a close colored friend, you start to understand that you are in the realm of individuals who may probably be trying, but don't necessarily have all the tools. It's exacerbated when you do have situations where, and this is true, I've been called the N-word on my unit by patients in practice. And the most that the staff, which is a very supportive staff, could do is stand in shock. And so it's a matter of understanding that we do have a long way to go. For my particular approach, I mean, I have to give a lot of thanks to individuals like Candace Shannon, who has really extended herself to try to create a community where you do have support. In this community, she clearly understands some of the challenges that all of the minority populations would face. So it has been helpful, and I do count myself lucky that I was able to meet her and have that experience as well. I'm not sure that it is like the only counterbalance that would work in terms of maintaining mental health, but you do understand and appreciate that at least there's someone in your corner, there's a community in your corner with respect to that. This is something that it adds to the challenges that you may have as a provider. I've had my credentials questioned by individuals before who could not believe that I would be providing services in this particular space when you have white counterparts who would not be questioned in that way, have not been questioned in that way. So you look at all of those individuals. I speak as well of my wife, who is a surgical oncologist practicing at Bassett Medical Center, who has had her credentials questioned, her capacity questioned, her existence overlooked, where people would assume that the resident or medical student is the provider and she is the nurse. So when you are in that space and knowing that there is very little to do to protect people such as ourselves from that, it does make it a challenge. But again, support like the safe space created by Candace Shannon and others like her, it really does help. And so more of that, I think, is useful in this realm.
Thank you. There is a question that sort of piggyback to that, which is, and this is for the panelists. What would the panel recommend for clinicians beyond required cultural competencies to do better at addressing systemic racism in healthcare, and what actions to take?
I guess I'll start off with that. We have just recently started a process of examining our staff, our colleagues with a questionnaire to get a baseline about where we stand as an organization. That will hopefully help us to craft educational programs to increase the knowledge of our staff and colleagues based on what those questionnaires show. So an overall educational program is something that we're hoping for. To speak to something that was earlier mentioned, as far as the isolation that we have here at Bassett in Central New York, being on this panel, this is the first time I've actually met Vince. And so that is, I find that shocking, but it's the reality. We're all busy clinicians. We have busy lives. And when we come home, we tend to hunker down with our loved ones and not go out, especially like 6 months out of the year. It's freezing outside. So I think we need to do more of that. We need to do more networking. We have to have more systems in place to introduce ourselves to each other and then to build those bridges to help strengthen that bond so that people don't leave because they feel that they're isolated. And in reality, there are people here that they could have been friends with.
I just wanted to say that for me, that goes true across all statuses, of course, gender, race, ethnicity, income level. In terms of people feeling welcomed here, you know, we can work on that as a community a little bit more cohesively.
Thank you. There is one question that is written from when an attendee and she says, as a white person in Cooperstown, I want to know what I am doing that could be perceived as racist. What can I do to change this? Can anyone on the panel share an experience they have had that could have been better handled? So I think the essence of the question is, as a layperson, how can we change this perspective, this take on healthcare and racism?
I can start with that. Not in terms of probably thinking of an experience right now, but maybe it'll come up later. But when we talk about racism and being racist, and you know, it's a very charged term. I think for, like you said, Carrie, a layperson, I think what it's important to realize that a lot of people are racist, you know, including, you know, as I said before, racism is internalized. People of color have very racist ideas about themselves. You know, what is pushed out in the media, pushed out in our educational system, it starts from kindergarten all the way through. You know, the public education system, it has many flaws, as we know, but you know, even that system in itself is educating our children. That system in itself does not address racism in an appropriate way. So I think it's important to realize that, you know, coming from that place, or what, you know, did I say something racist, or am I racist? The answer is probably yes, you know. And so I think once you understand that and stop fighting, oh, I'm not racist, the reality is you probably are racist. If you were raised in the United States of America, that's what America is known for. You know, it's institutionalized in every part of your life, in education and healthcare, in the criminal justice system, in sports, in, you know, every single institution, in politics, okay? Every part of our lives, we have this stain of, you know, this history that we've never dealt with. I mean, we have the state of Texas until recently, I can't remember, it's a couple of years ago probably now, that just started teaching the truth about the Civil War. An entire state, an entire educational system, okay, that just said, okay, we're finally gonna start teaching the truth about the Civil War and what it was really about. So, I mean, this is in the 2000, look, we'll have to look it up. 2018, 2019, 2017. This is recently. So, I mean, I think the place to start is if somebody thinks you're racist, you probably said something racist or, but that's okay. What you have to do is listen, okay? You have to say, no, I'm not racist, or no, that was not racist. You have to listen and you have to educate yourself on, oh, wow, like I never even thought about that. And it's not just about race. Like people say very offensive things or make assumptions about women or about, transgendered people or, all people come from a whole different histories, identities, and we say stupid things or we say things that were ingrained in our, upbringing that we don't even realize that is, really offensive. Even saying the word gypsy or like saying somebody, I got gypped, like I got cheated out of that transaction. I got gypped. That's actually offensive, because there are gypsy people in this world and you are equating gypsy people to cheaters, so you're calling all gypsy people cheaters by saying the word gyp. A lot of people wouldn't even think about that. I actually never thought about that until my husband told me that almost 20 years ago, so it's a learning process. If I have no gypsy friends, they're not going to say, you know what, I don't like that. I don't like what you just said. That makes me feel this way. And if you don't have any friends that are, of color or any white friends, or, if you spend all your time saying rude things about women with your guy friends and you don't actually have female friends, you might not know these things. So I think the important part is to actually listen. Listen and don't say, oh, I know how you're feeling because I'm a woman, I'm gay, I'm this, I'm that. You don't know how they're feeling. You want to listen to how they're feeling and don't try to transpose your own experiences on someone else.
I'd like to double down on that because what we can offer here is a distinction without a difference. We do participate in this racist system. It means that we will do and say things that are racist, but not necessarily see ourselves as racist. And this is one of the things that we have to be mindful of. People are very quick to take offense. And that's one of the things that needs to be addressed. If I say something that's offensive and somebody calls me out on that, it almost always does not matter what my intent was, only the effect. So I probably meant well, but I did more harm than good. The idea that we can listen to each other and accept that what you said hurt me is a very powerful position to take. And it does require some strength because, again, this coincides with a lot of discomfort that you would accept that somebody saying you did something to hurt me or you did something to offend me. And the fact that you did not mean to do it does not mean that this is not the effect that it had. So we have to acknowledge that we are in a system and this change did not come overnight, and therefore to eradicate all of these things that we see as problematic. It's not going to happen overnight. It's by incremental efforts on the part of everyone. There was another good point that Candace made with respect to spaces where there are specific groups that are not represented. And this is one of the things that I think is very powerful when it comes to addressing issues of race and this disparities in communities. If you are in an overwhelmingly white space, but you hear one of your colleagues, your co-workers, one of your family members or friends saying things that you can recognize as racist, do you stand up in those spaces and defend this minority population that is not there? Do you have the courage to go against the grain of your own family to say what you're saying is wrong, what you're doing is wrong? That's actually very offensive. I have a problem with that. And to me, that takes greater strength. It's easier to defend someone when they're right in my face. It's easy to do that because you are reminded that, look, this is wrong, and you can stand up there. Other factors come into play when you are in that space and there is no one there to supposedly take offense. But we know that repeated statements in private spaces is something that becomes ingrained. And we do not want that to continue to happen, which means we need to challenge these thoughts in spaces where representation may not be obvious. And that is where a lot of this hard work has to be done.
I just want to, again, great comments on it from everybody here, but the woman who asked the question, I think has to be commended for asking the question, and has obviously, in my mind, taken the first step. And everybody's going to travel a different path, and some will go fast, some will go slow, but I commend her for having asked the question in the first place.
And lastly, before we wrapped up, there is a comment that was put forth, which I would like to read because I think it's very accurate. The person said, "This is a comment, but I think it is important to acknowledge that many people in the community may have racist ideas without necessarily being overtly racist. We should move from being passive about racist ideas and racist practices to actively trying to be anti-racist. For example, reading anti-racism books such as How to Be an Anti-Racist by Ibram X. Kendi, and looking at other anti-racist resources. We must first start by educating ourselves, acknowledging implicit bias and racist ideas, and then actively work to correct these things." And piggyback to that, someone put up a, and I'm going to try to see how Leanne can pass it on to everyone. For anyone interested in examining their own implicit biases and inherent racism, Harvard has developed a series of quick tests. These are very eye-opening, and I have the website and here. I will try to pass it on and have Leanne pass it on later on.
I think it's also important to recognize that we have a lot of resources in our community. And I think that before we get cut off here, Gretchen Soren has put together a really impactful editorial and documentary, Driving While Black, on PBS. And I think that anybody on this call would benefit from having watched it.
I did try to send the, yes, and I think you did too, Carrie. We both tried to send out that URL from Harvard on the implicit bias. So hopefully people got it. But I really appreciate it. We're at 8:26, and so it's probably time for us to wrap this up. This has been a fantastic session, and you know, I feel like we just barely touch the surface on it. There's probably so much more. We could probably go on for quite a bit more, and hopefully we will. I think this is just the beginning of a lot of discussions going on here. So let me go ahead and I'm going to share my screen to make a few closing remarks. So hold on one second. So I just want to start by thanking my co-moderator, Carrie Fuertes, and tonight's panelists, Vince Solomon, Candace Shannon, Reggie Knight, and Jim Dalton, for just a terrific session this evening. And there's been a dedicated committee working both in front of and behind the scenes who have made this series a reality. We've got Carrie Fuertes, Joanne Gardner, Emily Gibson, Nancy Herman, Dottie Hudson, Karen Katz, Lynn Mavis, Molly Myers, Candace Shannon, Namita Sugandhi, and Callie Wright. And none of this would have been possible without the wholehearted support of the Friends of the Village Library of Cooperstown Board, as well as the Village Library of Cooperstown Board. So again, many, many thanks. And let me just close up by telling you what's coming up next. As I said earlier, this is the last of the Looking in the Mirror panel discussions for the fall, but please just want you to tune in to more programs being offered by the Friends of the Village Library on November 15. We have the second program in the Sunday Speaker Series that it's going to feature Professor George Hovis of SUNY Oneonta talking about the award-winning novel, The Underground Railroad by Colson Whitehead. And in January and February, as I said, in January and February of next year, we will be restarting the Looking in the Mirror panel discussion. We'll be talking about law enforcement, housing and historic preservation, culture and the arts, and then a culminating session on taking action where hopefully some of our panelists here will return to talk about that. You can register for any of these programs by going to fovl.eventbrite.com. And finally, if you have any questions or comments, please email fovlfriends22main@gmail.com. So I'm going to stop my share and thank you again very much to everybody. We had over 60 people attending, and thank you all for joining us. And we hope to see you all on November 15. So good night, everybody, and take care. Thank you very much.